Good morning, good afternoon, good evening. Warm welcome to today's webinar on AI and machine learning, shaping the future of healthcare. This webinar will explore strategies for and issues involved in bringing AI technologies to the clinic safely and ethically. The session will also introduce you to a framework for analyzing the utility of ML models in healthcare and discuss the implicit assumption in aligning incentives for AI-guided healthcare actions. We're delighted to welcome our today's presenter, Dr. Nigam Shah, who's an Associate Professor of Medicine, Biomedical Informatics at Stanford University, and his research focuses on combining machine learning and prior knowledge in medical ontologies to enable use cases of the learning health system. Dr. Shah was elected into the American College of Medical Informatics in 2015 and is inducted into the American Society for Clinical Investigation in 2016. He holds an MBBS from Baroda Medical College in India and PhD from Penn State University and completed postdoctoral training at Stanford University. Just to remind you about the format for today's sessions, just in case somebody is new to our sessions today. So it's an overall 60-minute presentation, 60-minute session that involves 45 minutes presentation and 15 minutes allocated for the questions. We will be taking the questions throughout the session. So if you would like to ask the question, please do either type it into the question or chat box provided or raise your hand. If you raise your hand, you will be in position to ask your question live. Now, without further ado, enjoy the presentation and over to you, Dr. Shah.
All right, thank you. And thanks for having me on this forum. So let's get started. The way I'm going to run this is I have a couple of slides to sort of frame the conversation and get all of us on a shared reference. And then I'll show you a few examples of work going on here. And then we'll conclude with a discussion of the utility and how safety and ethics issues should be handled as we incorporate machine learning into healthcare. So if you Google around and you stumble upon our group's website, generally speaking, the work is around using large amounts of electronic health records. And that means if you look at unstructured data and so on, about 8 million individuals worth of data. If we ask about claims and administrative data, about 200 million individuals worth of data over roughly 8 to 10 years. And there's also some other odd data sets that we use that are not typically available to researchers, but we have them through specific collaborations. So for example, we did a project looking at search logs of medical professionals on uptodate.com, which is a physician reference site, which some of you might be familiar with. Anyway, so by and large, medical data. And then with that, we do 3 buckets of projects. The first one is asking and answering specific clinical questions that a physician might have either at the bedside or at some other time. Then the second bucket is asking questions that the medical establishment should be asking but don't. So an example of that might be, what are the most common 6 drug combinations in the patient population in the United States? There's a lot of conversation about polypharmacy in the US, I'm sure maybe elsewhere in the world as well. And if you ask a clinician what is the most common 6 drug combination, very few clinicians can actually answer the question. So we're worrying about polypharmacy, but we don't know what the problem is. But that's very easy to answer using large amounts of data. And then the last bucket of projects is around making predictions. And I make a distinction between classification and prediction. And I'll give you examples of both. But as a general rule, I mean, if someone looks at an image and makes a prediction that it's a dog, well, that's not really a prediction. The object was a dog before they made the prediction. It's just a classification. Prediction is about something in the future. So just to make that distinction, that classification, prediction are different things. And then all of these projects have one purpose. They're all focused on bringing AI to the clinic safely and ethically in the next 3 to 5 years. So that's sort of the driving mission for most of the conversation as well for today. All right, so getting onto our shared mind map, I'll begin with a little cartoon of the healthcare system. So there's the individual and their family and support network who are in need of care at some point in time. Typically in the US, the first thing you do is actually go to the internet to figure out what you should be doing. Then obviously there is, oops, I don't know what happened. PowerPoint crashed again today, all right. Let's see what's going on. Start that again. Okay. So individual, you seek information typically on the web these days, and then you end up either interacting with the clinic, primary care practice, or the hospital. And then there's this intermediary, particularly in the US, there's lots of conversation about this, the insurance companies. There's a prescription involved for the most part. I mean, when you go to a clinician, about 3 things happen. You get a prescription, you might get a procedure, or you might get asked to come back. I mean, other than that, there's usually not no other outcome. And then there's large sectors of industry serving multiple constituents here, the pharma, biotech, medical devices, diagnostics. And then there's vendors of all sorts serving them. And they all try to interact with each other, increasingly trying to reach the patient directly and insurers to get their whatever the offering is approved, and then the government trying to regulate this mess and multiple transactions happening here. I mean, this is a sort of a cartoon slide. Each icon here is worth multi-billion-dollar industry sectors. But the reason to have this map is when you deal with data, it comes from some portion of this map. And depending on where it came from, it has different biases and different utility in terms of advancing or helping the care of patients. And that's sort of the main point of having this shared map of where does your data come from. And that's really important to answer and know before doing any analysis. All right, so that's one piece of shared reference. Then there's a lot of hype around big data. I'm sure most of you in the audience would have heard about big data in some form or fashion. For the purpose of this conversation, I'm going to ask you to consider this little cartoon. Imagine 3 axes. There's people as rows. There's features or characteristics of individuals as columns. And then we have time, the third axis, which is often ignored. And so if you imagine data coming out of an electronic health record system, you could imagine a little matrix like this, where rows are patients, columns are drugs, diseases, devices, procedures done to the patients, and then time goes in the third axis. And the important thing to remember is that there's 3 values. That the patient is on a drug, so let's say that's a 1. Sometimes we know for sure they're not on a drug, or a drug is contraindicated, or they do not have a disease. So an explicit negation, let's call that a -1. And then if we don't know, there's a 0. So it's also important to remember, because without this, a lot of common sense things to do in data analysis will not make sense. So a simple example, I don't have a troponin measurement in my medical record. It's because it was not needed. Now, if you try to impute troponin using other people's data in the observational setting, well, most of them will have had a reason to have that measured, and you'll impute an abnormal value for me. And so common sense things that make sense doing when you have prospectively collected data or clean data sets would not make sense when you're working with EHR data, and particularly large data sets on people that are collected and you're using it for secondary scenarios. So something to keep in mind. Then there's the claims data or administrative data. Typically, you have that for longer intervals of time. You have it on millions of people, but the feature space, the columns you get are fewer. And then there are the new kinds of data sets, such as the blue that I'm showing, a quantified self. Commonly, people talk about step counts, ECG measurements on individuals, continuous blood pressure, continuous glucose measurements, heart rate, and so on. Again, here, we don't have these data on lots of people. We do not have them longitudinally. And for the most part, in many cases, we don't even know what comprises a good feature. So everybody on the audience, I imagine, would have heard about variables and step counts. If you dig a little bit deeper, what we're getting is the normalized voltage of an accelerometer. And then some programmer who you've never met is going to apply an algorithm to it and convert it to an integer, which we call a step count. And if you happen to have two variables, put one on the left hand and the one on the right, and then by the end of the day, you get step counts that differ by 30% or more, which is physically quite impossible unless you were hopping the whole day or something. But I give this example just to illustrate that we don't even know what comprises a useful feature. And then the extreme end is the genomic information, which I'm the least knowledgeable about, so I just have that as to complete the mind map. The point there is that you have millions of features and you only have data on hundreds of thousands of individuals. If you're in the full genome space, maybe you can compile the genome of 50,000, maybe 100,000 individuals. But your feature space is in the billions in terms of base pairs. And so it's important to recognize this dynamic and think of something I call the NP ratio. So N typically stands for the number of samples, as in the number of rows you have in your data. P stands for the features or the number of columns. And if you're in a high N, low P situation, then statistics and mathematics works in your favor. If you're in a high P, low N situation, then you have to do a lot of mathematical acrobatics. And so as you think about problems, it's important to have this in the back of your mind, that where were the data generated and what was the NP ratio of the data set when it was originally created and given to you. All right, so with these data sets, you can think of multiple applications of healthcare or machine learning or artificial intelligence in medicine. And I find it useful to break it into three broad buckets. You can use data that you have and whatever machine learning algorithms that you're able to come up with to advance the science of medicine, which means to advance our understanding of diseases such as diabetes or cancer or what have you, with the goal to have more scientifically designed treatments and interventions. These kinds of activities typically happen in the School of Medicine or in R&D departments of pharmaceutical companies and so on. Then the second broad bucket of things you can do is to advance the practice of medicine. And here, the idea is to use information to deliver care, better care to the patient that is in front of you. And then the third is to advance the business of medicine or the delivery of health care, which is, can we improve patient throughput? Can we make sure we have predictive staffing of nurses? Can we do appointment scheduling that is cognizant of demand and volume at certain times of the day and so on? And typically, what happens is that the media hype is around the use of AI and machine learning to advance the science. And people pretend that if we advance the science, we will immediately advance the practice and the delivery of healthcare. And I would submit that nothing could be farther from the truth. And we have to be able to sort of sort out in our head that whenever an advance is being talked about, it's just about the science, the practice of the delivery. Okay. And then one more piece of sort of framing comments, that healthcare happens over time. So we have events happening in a patient's to a patient over time, and then we will have some record of that in the source that you're dealing with, given the incentive of that particular source. And so you might have a record of the disease somebody had, a prescription they got, or a procedure they had, some imaging study that was done to them. There'll always be some claims administrative data. There'll be streaming data if they're in the ICU. Somebody would have put a bunch of monitors on them. And then at some point, there'll be a measurement in the genome and so on. So this is analogous to the colorful matrix slide that we're looking at. And the colors roughly map to what I was showing you. But here I'm unpacking the time dimension and to make it very explicit that we will get some cross section of the data. And it's really important to ask, are they all aligned in time? Are they all aligned in time for the different patients for which we're getting them? Because without that, again, it's easy to make sort of trivial errors in the use of these data sets. All right, so now let's put it all together. Now, how do we find problems worth solving? So I've already talked to you about the science, the practice, and the delivery. And then the rows are the three broad categories of problems that machine learning can help solve. So solving a diagnostic problem is essentially classification, figuring out what does the patient have. A prognostic problem is a true prediction problem where you predict what will the person get in the future. And then the therapeutic problem is to figure out what you should do. So it's about recommending the action, or you could think of it as causal inference to figure out what needs to be done. So if we use this frame of reference, the things we're going to talk about today fall into these squares over here, the last two columns and the top two rows. And so an example of a diagnostic problem in the practice of medicine is figuring out who has, say, undiagnosed familial hypercholesterolemia. That's an example I'll use in the immediate next slide. So that's a classification problem. We're figuring out what the patient already has. And you can solve problems in either of these buckets, either of these cells, and tie them to a specific action. Now, the action can be ideated by a human. It does not have to come from a computer. But if you can connect a machine learning solution to one of these green dots that I'm showing, and I'll give you one specific example, which I've just highlighted in red for visual reference. If you can connect them to an action, you can advance the care and you can advance better practice of medicine. All right, so let's look at that example. So this is about finding patients who have an undiagnosed genetic condition, in this case, hypercholesterolemia. This work was done in collaboration with the FIND-FH Foundation, and Joshua Nolis, my colleague here, who's a cardiologist, was also heavily involved, and he has a pro bono role with the foundation as well. So the problem here is that this condition is a little bit rare. It's about 1 in 250 prevalence in the general population. And the estimates are that in a lipid clinic, it's somewhere between 1 to 90 to 1 in 100. Okay. There is a very effective intervention to treat these individuals if you can diagnose them. And there are drugs called these PCSK9 inhibitors that in the US cost quite a bit, about $12,000 to $14,000 a year, but they work like magic. And if you do not treat these individuals, they have ridiculously high cholesterol. Patients end up with heart attacks and cholesterol-related problems in their 30s and 40s. The problem is that given this 1 in 100 prevalence, in order to make patients eligible for those drugs, you have to establish the diagnosis. And the only reliable way to do that is to genetically sequence or genotype those individuals. But with a 1 in 100 prevalence, you have to genotype roughly 100 people to find the one case. And the economics just don't work out, because you would spend, even $1,000 a genome, you would spend $100,000 to find one case, and then you'd have to treat 7 or 10 cases over 5 years to make it viable at the population level, to make it worth everybody's time. So what we ended up doing is we took a few cases that were already diagnosed. Okay, I think we're getting some PowerPoint issues today. One more crash. So we took 110 cases that we had, and we selected 3,000 controls and put them in sneer codes because they're not really controls in the sense of being normal people. These are people who show up typically in a lipid clinic and have to be distinguished from a true positive case of FH. And then, okay, I think this PowerPoint is going to crash again. I see a little circle on my desk. I apologize. I have no idea what to do here, and it's stuck badly.
Nigam, if you'd like to send me your PowerPoint, I might be able to control it from here.
That it is worth trying, but I think the problem might be something else.
Okay.
Right now, I can't do anything in my computer. It's just frozen.
Right, okay.
It's early morning here, so my computer might also need some coffee.
Coffee, I know. So we'll just give it a couple of seconds, see whether you can reboot it and come back to us as soon as you can.
Yeah, but right now I'm just trying to get out. It won't even escape. Nothing's happening. And I just have a little circle going. So I might have to force shut down and come back to the call or.
Yeah, if you
Hold
do
on.
that, yeah.
PowerPoint not responding. Quit.
Quit, yeah.
All right.
That's it.
All right. So I don't know what's wrong today because I present using the exact same computer. Maybe it's some weird interaction with GoToMeeting.
Yeah, it's probably too early in the morning as well.
All right.
So I think we're back in business.
We took these 110 positive cases that we had and the patients that need to be distinguished from them and build a classifier. Imagine it in your mind as something like a spam filter that figured out spam from not spam. And we got good performance on the classifier, and these are all internal validation numbers. And in case it's great, we can figure out the 110 cases we knew from other patients that show up in our clinic. And then we applied that classifier to potential cases, as in patients who come to the lipid clinic, and some of them were flagged by the classifier. In order to do this, to convince ourselves that this is indeed useful, we did manual chart review, and we found that of the top 100 predictions, 79 out of 100 were correct in the sense that they would need to be followed up, and a physician would have some concern they might have this genetic condition. So the advertised positive predictive value, or at least the one from the technical validation, kind of held up in our own data. We then went to a Geisinger health system that routinely genotypes and sequences people just as part of their normal operations, and they had 466 cases. We couldn't get that many matching controls, mostly for data use agreement issues, but we got about 5,000. And in that, again, when we applied our classifier, we were able to identify true cases with roughly the same performance, a little bit drop given the different center. But once you're able to do this, the economics change significantly. Once the classifier has flagged somebody, the chance that they are a case is 7 or 8 out of 10. So now I have to sequence 10 people, so $10,000 at $1,000 a genome, and I find 8 true cases. Now, if you're the company that makes these drugs, this makes a lot of sense as a companion diagnostic because by spending $10,000, you get $84,000 to $90,000 of repeat business every year. If you're an insurer, you pay for the care of 7 people with FH for 5 years, you prevent 2 to 3 heart attacks. So that makes sense for you as an insurer. As a doctor, this is great because now you're actually able to find the cases you were missing and you're providing better care to your patients. And of course, it's great for the patients because we are missing these individuals and now we're able to find them and provide them with the right treatment. So the whole point is to think of this triad of patients, the providers, and the payers, and of course the pharma company that makes these intervention, and to realign the incentives between them by the use of an algorithm or a machine learning classifier in this particular case. So that's sort of the point of my thinking right now, is that we have to think a little bit broader than a specific use case and a specific disease, and use algorithms in a way that we take out the friction between the providers, payers, in order to get the right care to the patients at the right time. And so therefore, this is sort of the last slide, and I already went through one example of a classification in the process of completing our shared mind map. And then a couple of other things that I would like to share with you is, in doing any of these actions, or solving any of these problems, you would need to have a clear data strategy. And what I mean by data strategy is that data will be thrown at you from some portion of that idealized health system map that we're looking at, in the form of relational tables, in the form of, okay, this is not good. Okay, I'm going to have to skip a lot of the presentations because of we're losing a decent amount of time in this. All right, so relational tables, you might get notes like this. You might get ECGs or some other form of live traces. You might get social data. And your job will be to then take that mess and convert it to this nice table that you can then use for whatever problem you're trying to solve. And data will be given to you in one of these random formats, and I've just listed a few sources that typically get mentioned in the US. The top 4 are data models that you find in the in people who do observational data analysis. The bottom 4 or 5 are things that people who run health IT systems care about, and of course they don't exactly interact with each other nicely. But from a researcher's perspective, you're given stuff on the left, you have to get to the right, and you need a clear strategy for doing that. And that strategy has to be cognizant of the biases under which the data were generated and the particular problem in the science, practice, or delivery that you're trying to solve. And then as you do that process, as you go from these sources to creating these columns, these features, there's 2 ways you can approach that problem. And what I have on this busy slide is the patient is in the center, the blue arrow, and you have the different kinds of data that can be produced for them. So we have some coded data with the hashes and the dot, some lab tests, some prescriptions, what have you. And then typically in executing the data strategy, we do things that are at the bottom. We will take the record and we will then count the number of codes that somebody's record had at a point in time. We might do a binary yes, no. There might be some distinction made on the basis of time, as in what was old features and what are recent. And most of the times those distinctions are arbitrary. You know, is 6 month recent, is 1 month recent? People make ad hoc choices based on the analysis. We can look at things over time, so that's the derivatives. So for example, you can count the number of specialist visits a patient had in Q1, in Q2, Q3, Q4, and then see if the rate of those visits is going up or going down and what have you. So those are all manually engineered features or hand engineered features. On the top is using a computer to learn the features. And that's commonly called representation learning. It is a step that happens while you're throwing fancy deep learning at your problem. And a good mental model to remember this is, let's say you're trying to build a classifier to distinguish images of a house from an airplane, from a ship and a motorcycle. As you set up that classification problem, the computer has to learn how to represent the image, go from the raw pixels to an internal representation that is useful for discriminating whether the picture you're looking at is a house, an airplane, or a motorcycle. That's what these little colorful dots and and the high level feature rectangular box denotes. In that process, at some point, you get a representation that is reusable for other tasks. So you might have built those features to discriminate a house from a motorcycle, from an airplane, from a ship, but then those same features, that same representation, is useful for finding similar images, for example. And you can do the same exercise with electronic health data and have features or a representation of the data that you learn directly, as opposed to create yourself in the form of the ICD-10 codes or ICD-11 codes or the CCS categories or what have you. And then the third piece of your data strategy is the cost and utility trade-off. Because constructing the features, acquiring the data in order to do that takes time and effort, and of course, in some cases, monetary resources. And then having or not having that feature has some utility for the problem you're trying to solve. So for example, if you're trying to use data to predict who will be newly expensive next year, socioeconomic data are of limited value. In fact, you don't get much improvement in your prediction accuracy. But on the other hand, if you're trying to build a model for who will engage with you if you interact with them to improve their care, it's often called patient engagement in the US, socioeconomic data is immensely useful. It's priceless. And so a particular feature that is useless or of limited value in one scenario becomes extremely valuable in the other. And that's getting at the utility of having or not having that particular feature. All right, so that is sort of the brief framing and overview along with the mind map and everything that I shared with you. We're at about 30 minutes. So we have, let's say, about 10 minutes left. And I'm going to give you one example from each of the three buckets that I laid out: the answering clinical questions, insights, and making predictions. And I've already given you one example of classification. So on the answering clinical questions, typically what happens in healthcare is you formulate a question. We'll spend 3-6 weeks or maybe a couple of months creating the cohort of similar patients. We'll do an analysis. We'll publish in the Lancet or the JAMA or whatever is the top journal of the continent you're in. And then there'll be a press release, and then everybody will forget about it in the next week. And we also played that game for a while and then got bored. And so we launched this service, which you can find out more about at this URL, greenbutton.stanford.edu, to produce real-time or near real-time reports for doctors who have questions about what happened to other patients like mine. And the idea is that at the bedside, so in this cartoon, the question that corresponded to this particular patient was they had an incidental finding of an intraatrial septal defect in an otherwise healthy 18-year-old child or young adult. And the doctors had the question that whether we treat with antiplatelet agents or anticoagulants, what is the difference in the rates of downstream cardiovascular events? There's no clinical trials, there's nothing in the textbook. And we were able to produce a report of what had happened to similar patients in our the Truven Market Scan database. In our Stanford Clinical Data Warehouse, and provide feedback to them about the specific rates. So that's what I mean by answering clinical questions, in this particular case, at the bedside using aggregate patient data. And you can find, there's a little video at this URL and so on. In order to answer such questions fast, we ended up building a search engine, because the classical way of managing data and building cohorts and answering and doing observational studies didn't work at the speed that we needed. So here's a screenshot of that search engine, and at the URL that I showed you, there's another 2-minute video just on the search engine. And you can search, we can search for diagnosis and procedure codes, we can search the clinical notes and vitals and so on. And then once you've identified your criteria, you get a view like this where each row is a patient, each color is showing you the particular duration in which the condition you cared about was true. And that goes back to this notion of always looking over time. And you can, this is a URL where you can find out more about the search engine, also linked from that other one. Okay. We've done about 83 consults to date, and they fall into these buckets of, having a causal inference question, doing survival analysis, or time to event analysis, broadly speaking. And the largest category is just exploratory questions of the form, how often does XYZ happen? And there's a few examples of each of these questions, which we will not see because of Microsoft. All right, I'm going to skip the examples because we're running a little bit behind. But the slides will be shared, and then you can look at examples of the kinds of consults that we've done. All right, the second bucket was producing insights or asking questions that the health system should be asking. So here, I'll just use one example. This particular image is from a study we did as part of the Observational Health Data Science and Informatics project, which is coordinated out of Columbia University. George Herbstack is sort of the main scientific leader. This paper is from the Proceedings of the National Academy of Sciences. What we're looking at is the first line treatments of diabetes. That's the innermost circle. The color tells us the drug. The second circle tells us the second line drug. The third is the third, fourth, and so on. And this particular study was just purely descriptive to ask the question, what are doctors doing? How is diabetes treated worldwide? In this case, using data from about 250 million patients. And as we would all like, about 75% of the time, it is the case that metformin is used as the first line treatment, as suggested by both the American Diabetes Association and the American Endocrinology Association. And then we see that for the second line drugs, there's very little consensus. People go from metformin to glipizide to sitagliptin to pioglitazone with roughly the same frequency, which is also not very surprising because the guidelines don't really give a clear suggestion of which one over the other is better. They just say, they lay out some pros and cons and say, essentially say pick a drug. So this is descriptive. This in itself was exciting because to date, no one has characterized the treatment of diabetes at such scale. And in this particular study, actually, we did diabetes, hypertension, and depression worldwide. Then the next question the same group asked was, does it work? So in this case, if you go from metformin to sitagliptin to pioglitazone to glipizide, which one is better at getting your A1C under control? And this study was led by Stanford, again, the same collaborators that we had in the previous study. We used data from about 7 sites and asked the question that from the previous treatment pathways that we looked at, going from metformin to one of those 3 drugs, which one reduces your A1C faster? And I'm just showing one of them, comparing the DPP-4 inhibitors with sulfonylureas drugs. And you can see the number of people on whom this ascertainment is based. And then if you look at the hazard ratios, I mean, the bottom line, there's no huge difference. There's a minor difference in one of the 2 comparisons that one of the 3 comparisons we made. This paper is coming out soon, and I'll just leave it there. All right, and then the last, just to wrap things up, I've already given you an example of the classification kind of problems, and let's quickly look at one predictive problem. This is really annoying. What's really needed is to reboot the computer, but that's going to take 5-6 minutes. So we'll just.
It's not going to resolve the issue. We just received the email from one of the participants saying that the problem was just reported recently. It's after the new Apple update to Sierra. There is an issue that is happening. It was just PowerPoint, so it's a Microsoft issue. So rebooting the laptop or computer would not solve. Unfortunately, we didn't know that that's going to. So apologies to our participants and you also, Dr. Shah, for kind of having to go through this.
All right, well, at least it's not my computer.
No, it's not.
All right, so let's look at the last example. This is about palliative care in the United States. So this map, I promise you, has nothing to do with politics. What it is showing is the quality of palliative care that patients receive in the different states in the US. And red is bad, blue is good. And palliative care has an interesting dynamic in the US that about 90% of hospitals with are large enough, which have more than 300 beds, will offer palliative care services. It is estimated that 7 to 8% of admissions need palliative care, but only 3.5% or 3.4% of admissions get palliative care. So about half of the eligible or less the people who need it. And then if you ask the question, when are they offered the care? Turns out that the majority of them get it too late. And the numbers are shocking. I mean, if you ask how many of them get palliative care 6 months or prior to death, the numbers are like 0.08%. So it's just terrible. And there's randomized control trial-based evidence showing that when patients get palliative care, they have a better quality of life, they live longer, and they cost less. So there's absolutely nothing to like. And just one more statistic to hit home the point. When surveyed, most people, the majority, 85% or so, say that when they want to die, they want to die at the home surrounded by family. 75-80% of deaths happen in the ICU. So something is wrong. So we said, all right, could machine learning help this problem? So the current way palliative care works in most places, there's a patient and the treating physician recognizes that there might be need of palliative care and they will pull a palliative care specialist into the conversation. And we already saw the numbers. These are actual numbers from Stanford Hospital, Stanford Health System over the past 8 years or 10 years, and we're basically right at the middle with everybody else. 3.5% and very few cases getting it 6 months prior. So we said, could we flip the model? Could we make it into a prospective, could we use a computer to flip this model instead of relying on the judgment of the treating physician? Okay, so now it's time to reboot again. Come on. Oh dear. Right now, I've lost total control, so it's not even crashing.
Let's just, I think it's just gonna have its to run its course before you can exit out of the PowerPoint, before it allows you to exit out. So we can take a couple of questions maybe from the participants while we're waiting, and hopefully we will be able to get back in. There's only a couple of questions here, so I suppose if you're okay with that, we can take them now.
Yeah, sure.
And then we encourage the rest of the participants, if you have any questions, type them into the question and chat box provided, and we'll do our best to answer them all. Here you go. I think you're back. So I'll let you continue first because you were in the middle of describing it, and then we'll take the questions later.
Okay. All right. So here, the idea then is to have a computer reading the charts of patients who get admitted every night, and the computer then flags a case for care by the palliative care physician. So instead of another human making that ascertainment and pulling in the palliative care doctor, we offload that grunt work to an algorithm that runs on everybody and then prioritizes who should be seen by palliative care. And then they will talk to the treating physician to say, does it make sense? Should we actually have the conversation? So there's two humans in the loop before a conversation initiates with a patient. And so again, going back to the timeline, there's a time which let's call that the prediction date. We have some observation window, which is in this case, the data that we have on the patient before they got admitted or just the day of the admission. And then in this case, we're predicting death 3 to 12 months out. And I make a big deal about this because it needs to be far enough out so that you have lead time shown by these horizontal red arrows or red lines with arrowheads at the end to allow the health system to take some action. If you make this exact same prediction 24 hours ahead, it's not that useful. If you make it 2 years ahead, it's still not that useful because the patient and the people are just not ready to have that conversation. So 3 to 12 months is the right window to execute on this particular prediction. And then at the bottom, I'm just showing the performance criteria of the model that we built. And the point I'll make here is we typically look at AUROC. In this case, that makes no sense because the outcome is low prevalence. So we should be looking at area under the precision recall curve, which is what's shown on the left-hand side. And then the right-hand side is another aspect of predictive models that is often ignored in healthcare, which is the model calibration. As in, for the people in whom we predict a certain probability, in this case, say 75% probability of death, if we do that for 100 people, do 75 actually die? Because you need good calibration if you're going to make decisions based on that model, particularly if you're going to make decisions about individual patients. And there's lots of models in healthcare, like the Apache score and so on, which have good AUC, good discrimination, terrible calibration at the individual patient level, and precision recall curve left unreported. And those models are notoriously difficult, or I would say even not appropriate for use in a individual decision-making situation. And so that's sort of the main point I want to hit across, that if you're in a predictive setting, pay attention to the time you're making the prediction, pay attention to the observation window that you have, and pay a lot of attention to these lead time, the horizontal red arrows, the amount of time given to you by the model to take an action in response to the prediction. And that's absolutely critical. And then you need to be looking at precision recall and model calibration to decide on the actual action. All right, so last slide to close out is if you're deploying these kinds of interventions into practice, when you see a model, I want you to ask 3 broad categories of questions. First, what is the kind of use case at hand? Which means going back to this diagnostic, prognostic, therapeutic. I've taken out the science one and I'm calling the delivery as operations here. And so what I just showed you is a prognostic use case in the medical or clinical setting, the palliative care setting. Really pay attention to who will decide on the action to take. We keep 2 humans in the loop. If you have a computer just making the decision, I think that's a recipe for some trouble. And then what are the assumptions being made? Particularly assumptions about the existence of an alternative action to take, in this case, a conversation about advanced directives, the need for interpretability, because clinicians or most people in the medical profession, you show a prediction model, they say, well, can you explain the prediction? And I say, well, why? What does it even matter? Because in this particular case, what matters is that your prediction is correct. And to give an extreme example, there are projects where we worked on making predictions for 24-hour mortality. Then you spend a lot of time explaining them for interpretability. And the explanation is, the patient has metastatic lung cancer, they have septicemia, they have bed sores, and so on and so on. And therefore, the model says they'll die. Okay, so what? I mean, you're going to cure their metastatic lung cancer in 24 hours? So many times the need for interpretability is actually just a call from the medical professionals to give them information to trust the model. In healthcare, we use a lot of drugs, which we have no idea how they work. So they're uninterpretable in terms of their mechanism of action. But we use them because they're being tested prospectively in a randomized setting. We can do the same thing for predictive models and the interventions that are guided by them. And so whenever someone is arguing about interpretability of a prediction model, tease it apart. Is it really interpretability, or are they asking for proof that the thing actually works? And then always look at the incentives and the ability to take action, because weird stuff happens if you don't look at them. So that's the sort of, if you want to take a model to practice, at least ask these three broad buckets of questions. And then with that, I'll conclude. There's lots of people involved in this project, some of them members in my group, some of them collaborators elsewhere. There's no way I could list all of them. I've only listed people in my team, and then funding from a variety of sources. And I often joke that in 2014, we wrote a paper, a vision paper, about using aggregate patient data at the point of care. And then in 2017, we're actually doing it at Stanford Hospital. So with that, I'll close and happy to take questions.
Thank you so much, Dr. Shah. And we will go straight to the questions. We have a number of questions lined up. Just to remind the participants that there's still time to ask your questions. Just use the question or chat box provided to type your question, alternatively raise your hand. So we'll take the first question if you're okay, Dr. Shah. It's from James Robley from Canada. He's thanking you for this excellent presentation. And he's referring to the European Union General Data Protection Regulations that are now in effect. In North America, we don't have regulations that are as stringent. The GDPR, amongst other provisions, requires that the individual is the owner of the information and has the right to remove data from the person or organization that collects the data. What effect do you anticipate with such provisions have on the general area of big data and artificial intelligence in healthcare?
So there's two levels of answers. The official answer I will give is that I'm not a lawyer and I can't comment on the legal interpretations of the Data Protection Act. The answer that I can give as a colleague is that I think that can be solved with consent. The health systems in most countries use patient data only with and after consent. And if you apply that rubric, then the same procedures that you follow for consent can be applied for the use of patient data at the point of care. Now, the problem becomes the huge cost of reconsenting the millions of people whose data a health system already has. I view that as a logistical problem. And yes, it will cost money and resources to reconsent the individuals. But if you set up a process that every time somebody comes back, you consent for their use of data for research, in about 1 or 2 years, the entire population that is in a health system can get reconsented. So it is going to create a headache in terms of the logistics of it, but I don't think it is philosophically incompatible with the use of aggregate patient data for better decision making.
Thank you so much, Dr. Shah. The next question here is from Rajiv Agarwal, and he's referring to artificial intelligence having issues with crashing, hanging, and making data not accessible, as the case has been in this presentation. And it also creates a havoc in medical care. So do you think we should use it as an aid rather than depending on it totally?
So that depends on the level of comfort with technology, and I would argue that as close as 20, 30 years ago, in many places in the world, we were doing complete blood counts manually. You would take a blood smear, you slide it out, and then zoom around in a microscope to count the different kinds of white blood cells somebody's seeing. In most places right now, that procedure is done by a cell counter, which is a completely automated process. And it took a few years to get there. And so I would argue that a lot of processes, so blood pressure is another great example. When I trained, we used to take blood pressure with a mechanical instrument and actually try to listen with a stethoscope for the sounds. These days, it's a tiny computer. You attach the cuff to the patient, and it keeps taking measurements, whatever, every hour if you need to. So AI is not yet at that level of trust and pervasiveness, but it will get there faster than we imagine. And we should be thinking about ways in which we can design care delivery processes that are aware of the possibility of that happening.
Thank you so much, Dr. Shah. And another question here, there are two participants that are inquiring about it, but are there any plans to consider this model in poor resource setting?
Absolutely. So the modeling requirements will change. And so the FH model, for example, or the mortality model, for example, as is probably not portable to another setting. But we're actually working with another health system close by to work on a model for advanced illness management need prediction using just primary care outpatient data. And we're able to build a prediction model and get it to a usable performance. It's not going to be as great as the inpatient setting, but it is high enough accuracy that you can then design an intervention in order to benefit a large number of people using that. So in my own work, I only have one example, but I'm sure there's lots of people working on using predictive modeling in the low resource setting. A great example that comes to mind are projects around maternal and child health in lots of developing countries, where by using mobile phones by primary healthcare workers to monitor the health of a pregnant lady, you can watch for trends over time that would have been missed if that monitoring was done over paper, and can be used to predict high-risk pregnancies and take appropriate action for them as an attempt to have the delivery in a hospital instead of in their home, for example.
Thank you, Dr. Shah. The next question here is from Luis Ako Agba. Hey, thanking you for this presentation. And his question is, how can AI and ML models make use of the social and environmental determinants of diseases in making diagnostic or prognostic predictions in real time?
That's a great question. So we've dealt with social data just a little bit. So I gave you that example of UpToDate.com, which is mostly health professionals searching. So it's not social in the sense of Facebook and Twitter social. Search volume doubles in July and August. And for those familiar with the US health system, that's when the new residents come in. So that's mostly sort of a amusement thing. But by looking at the search behavior of physicians, we could see their change in behavior in response to FDA drug alerts. There are projects that I'm aware of, but not part of, at using people's search behavior or their social media behavior to identify individuals who might be depressed and prospectively reach out to them. There are lots of projects around trying to use social media to flag suicidal behavior, particularly among teens, so that mental health interventions can be applied before it's too late. Amongst the leaders in the space of using social media or just unstructured data on the web writ large for better healthcare is a person called John Brownstein at Harvard University. And so if you just Google for his name, you'll see a lot of great examples.
Thank you so much, Dr. Shah. And we have one more question that we're going to wrap this session with. Well, it's not a question, it's rather a comment that from Gyan Mikand Bayona, who's thanking you for this fantastic presentation. And he's hoping to see the IA's success in the future. And on this note, I would like to thank you for delivering this fantastic presentation, going through all of the crashes of the system and kind of keeping a presentation and the participants' interest intact. So thank you so much for bearing with us and the technology, and thank you for sharing your expertise with our participants.
Well, thank you for having me, and I'll send the slides over, and then we can post them in case somebody wants to review.
Perfect. Thanks very much, and goodbye.
Thank you. Bye.